Okay, let's go ahead and get started. Thank you all for coming this morning, and please feel free to come down closer. Ira Glick says he would appreciate a more intimate setting, so feel free to come down if you like. My name is Owen Wolkowitz. I'm professor in the Department of Psychiatry, and Ira asked me to introduce him because I've known him for about 30 years, but looking around the audience and Nick Canis and his wife, I said some people know him even longer than 30 years, but I'm very delighted to introduce Ira. He's been a friend as well as a colleague. I'd like to just briefly, his CV is incredible. I only saw the one-page abridged version of it, and that was incredible. So I'll just go over his Bay Area history. He started off here in the Bay Area as an assistant clinical professor at UCSF in our department, 1968 to 72, associate clinical professor, 72 to 76. He was chief of the clinical research ward at Langley Porter Psychiatric Institute, 68 to 78. He was the director of medical student education at Langley Porter, 75 to 78. I didn't know these things. And professor in residence at UCSF, 76 to 78. He's sort of bi-coastal. He started in New York, came out here, went back to New York to Cornell Payne Whitney. And while on the East Coast, he was the senior scientific advisor to the director of NIMH from 88 to 90. He came back to the West Coast to Stanford, where he was a professor from 93 until the present, where he's now emeritus professor. At Stanford, he was the director of the inpatient and partial hospitalization services from 1993 to 2000, and chief of psychiatry at the Palo Alto VA from 95 to 96. He has a long list of awards and honors, which I won't go into, but trust me, it's very long. One thing that people may not know about Ira, I didn't know this either until I did a search this morning, is Ira's an avid basketball player. And he was written up in the Palo Alto Weekly, and I'll just read one quote here. Let's see. While lecturing in Casablanca, Glick sought out a basketball game. After much effort, his guide found him a large gymnasium. Young Arab and African guys threw him a ball to shoot hoops on his own. After they watched him shoot, they asked him to scrimmage. 2 hours later, they ended up trading jerseys. On the way out, Glick learned that they were players on Morocco's top professional basketball team. So aside from that, Ira's lifelong research interest has been in schizophrenia, and I'm very glad to introduce Ira now to speak about his work. Thank you, Ira. Thank you for coming.
Thank you, Owen. Owen was kind enough to do this. This was all put together at the last moment, and I am thrilled to be back, to tell you the truth. It brings back such wonderful memories of the students that taught me everything that I had that I know, and they're not responsible for anything I say that it's wrong. And the research that I've done, and actually this study that I'm doing, that first slide, by the way, usually gets a big hit around the country, but here it's routine for you, the view of Baker Beach. But this study has really been a labor of love, where I've tried to look back on what we've done and see how it worked, which has really been my career. I started it here with doing the long versus short hospitalization study, the first NIMH study, comparing outcomes of different kinds of hospitalizations. And then I went into doing different schizophrenia and mood disorder outcome research. But basically, my career has been what happens to people after we treat them. And it's been a lot of fun. So what you're going to hear today is a follow-up of patients that I did from over the last 20 plus years from Stanford, plus one UCSF patient who I've known for 50 years. So this will be interesting to you. The point of the study really is that we need to think of treating our psychiatric illnesses the same way that they do in medicine. That is, I see some nodding heads, thank God. These are lifelong genetic illness, most of them, and they need to be treated over a lifetime. It's not something you take an aspirin and it goes away. And I hope to convince you with this with this particular study. So the objective of what I'm doing today is to speak about lifetime management of this disorder, but it can be equally applied, I now know, from my colleagues around the country in bipolar disorder and in depression, and probably also other disorders. We're going to do a seminar on this at ACNP in December. So the real message for schizophrenia is we have objective treatments, and it's all about compliance. And what you should do is get started in the acute phase, looking ahead for the next 20, 30, 40 years. And you do whatever it takes. Nick, one of my students, Nick Canis, who's here, who's a distinguished professor here, was just saying, are you going to talk about psychotherapy? Of course, in addition to medicine. So I'll also emphasize that. And the goal for the patients is to improve the quality of life. And for the medical students, are there any medical students in the audience? No. Yes. Oh, great. For the medical students and the residents. Any residents? Oh, fabulous. Okay, got somebody to help me get through this. This is a disease that is actually, you can actually help people, and it's really fun over the long run. Damian Rose, who runs a schizophrenia program, can tell you a lot about that here. So this is, I'm going to give you the best tips I can on what to do. All right. Having said that, I'm going to run through the slides. I'll talk for 45, 50 minutes, and then leave plenty of time for questions, etc. So, by way of disclosure, I work closely with with industry in developing drugs through my life, and I even have a little stock in J&J, which I think I got years ago. The message, as I said, is 1, it's a lifetime illness, schizophrenia. 2, treatment. Our treatments help, but only partially. Side effects, I'm going to talk about, and what I'm going to tell the residents is try to learn a few. Each one has a different profile. And my colleague, John Davis, who worked with me on the article that we did, has been telling me shared decision-making with the patients and family. The only issue, the difference between families with schizophrenia versus families with somebody who broke their leg is you don't have the cognitive disorder. So I make a point of saying you're going to end up making more decisions than you want to make, but you'll do it on behalf of the long-term functioning of patients and their families. And the key pearl here is, the takeaway message is, take your medicine. I'll break this down to a brief introduction, stuff that the residents know backwards and forwards, the methods of how I did this, the results, and then the key part of the talk really is the discussion, what to do as you follow patients over 20, 30, 40, 50 years. And then just a brief conclusion. And I'll use the slides just as prompts to make the teaching points. This next slide is looking ahead. This was, while I was here, I had a Rockefeller Fellowship, spent a month in Bellagio suffering, looking out over Lake Como for a month while I wrote one of the long versus short hospitalization study up. And by way of introduction, you know this again backwards and forwards. Schizophrenia is around the world. It's 1% incidence and prevalence. It's a disease of a series of relapses and remissions. And I'll show you patients don't go back to their baseline functioning. And what you want to do is avoid relapses, because each time you relapse, the brain changes and prognosis goes down. And what you're trying to do is raise quality of life. That's that education. And it has a high mortality rate for a variety of reasons. So what you want to do is pick the best possible treatment. And I'm going to tell you that we're not thinking, Davis and I are not thinking anymore of first, second, third, fourth generation. All the antipsychotics work but only partially, and some are better than others, and I'm going to hit that point home. The residents are going to know what the 3 best drugs are, like their middle names. And I like to start the talking about Will Carpenter. From Will Carpenter, what he says is that this is a really difficult disease, but you don't always have a downward prognosis. And that what clinicians should assume that with good treatment, you can raise the level of function. And how good you are as a treating clinician will very much affect how the patients do. Now, this next slide is very important because, let's see if I can, what it shows you is the patients come into Langley Porter, they're students at UC Berkeley or Stanford, and they've functioned very high level. And then they're here on the inpatient services, teens at 10s and 20s, and they keep relapsing, going on and off their medicine. 90% of patients, Lieberman and I studied the first episode study, and then the idea is to stabilize them and get them up, going back up in terms of functioning. And the one key thing to show you is, though, even when you stabilize them, you don't get back up to the high functioning level that you're at. But nevertheless, you can do something to help people actually have terrific lives. I like to bring always multimodal stuff, and I brought an article from Psych News on Ellen Sachs, who's the professor of law at USC, and often refers patients up here to us. And she's got schizophrenia, well treated, I might add. So that's a key slide. Next slide I got from Danny Weinberger, and it's just by way of saying, this isn't a neuroscience talk, but it's by way of saying that these are genetic illnesses that impact on the symptoms, the behavior that you see, and interact with the temperament that you're born with. But there's a lot going on in the brain that we don't understand in terms of cells, systems. Suffice to say for this talk that we don't know exactly what's going on in there, but our medicines help a little in terms of long-term outcome, in terms of doing something to stabilize systems, function, thinking. This is the kind of stuff that Marty does in his sleep, talks about behavior and different disorders, and we'll talk more about this as I go through. But again, this is also an important slide to set the stage for what I'm going to talk about. And the big issue is, because of the disturbances in the brain, whatever they are, dopamine et al., you can't think. And cognition is the key element, despite how bright you were at Stanford and at Berkeley. So when I was here, what we used to focus on was acute treatment, lowering, you throw in that Haldol, treat as high, go up 20, 30, 40 milligrams of Haldol to try to do something about the acute psychosis. But the real focus of what we want to do is be thinking ahead in terms of getting the patient stabilized and then gradually increasing their function, avoiding relapse, picking our best medication with minimal side effects over the long run. Again, so that these two slides are setting up what I'm talking about. And what we're focusing on is the social and occupational function. We want our patients to be working, want them to have relationships and be able to take care of themselves. And you all heard last week Lisa Dixon, terrific talk on getting new evidence-based stuff into the overall prescription. Lisa, again, from my past, when I left here, went to Payne Whitney, the first day I was there, I was sitting in my office, and a woman walks in and says, I'm a PG2, my brother's got schizophrenia, and I want to work with you. And that was Lisa Dixon, and she's had a fabulous career focusing on just this kind of stuff. The point I want to make for the slides are, our drugs help the positive symptoms. They will help a little the negative symptoms. They help a little in terms of mood. I'm going to tell you, don't use antidepressants. They don't help, because the main symptom is not depression. It's this demoralization as patients think about their future. And the thing we can't do much about is cognition. We don't have any cognitive enhancers. But having said all that, our job is to maximize what we got and deliver it over time consistently. This slide, again, I got from Jeff Lieberman, just showing you the evolution of our antipsychotics over time. Was until the 90s. We got the four horsemen here: clozapine, risperidone, olanzapine, quetiapine, and then ziprasidone. And now we've got three and a few more that I didn't put on this slide. I'll speak to that in a minute. So the new model then is to think about schizophrenia as a genetic syndrome with multiple domains of dysfunction. And it has to do with genetics, developmental processes, disease, and they're separate and independent, and each you need different mechanisms and different treatments. Again, it's by way of saying this is a complicated, complex disease in our complicated brain, and we don't know exactly what's wrong, but we give whatever works and make sure we do it. Again, I can't resist saying that I'm indebted sort of for that concept, not only for Danny Weinberger, but for Dave Braff, who was a resident here in PG3 in 4 years, and now he just won that $100,000 Alaska Prize on his genetic research. But he tells me it's impossibly complex to figure out what's going on with the genes. Nevertheless, we'll move forward. I was visiting professor in Bari, Italy, where the migrants are now coming. This is from a castle that's, again, by way of saying it's complicated, beautiful, octagonal, one of the world wonders. And the way I pulled together our meta-analysis was to get everything we could find in the literature. John Davis and I did that on 2 different occasions. We've had papers in the archives, and we went through all the world's literature. I had my kids who went to Chinese American school here do the Chinese literature, and did all kinds of things. So the evidence I'm going to give you is the latest data on what works and what doesn't. I want to right off the bat, at the beginning, again, go back to that cognition thing in terms of functioning. The latest word from Rich Keith is that when you get schizophrenia, obviously your IQ goes down 10, 20, 30, 40 points. Our medicines, all the antipsychotics, will help, but only a little. And what Sophia was doing, the third point, cognitive remediation, will also help a little. We still need controlled studies on that, but it's a promising lead. So I'm advocating medication and psychosocial functioning to improve cognition. All right, again, another slide which has no particular resonance here. I took this one night in a night class, and this was on the cover of the American Journal, by way of saying when you talk about results, it's interesting, different, and unusual. To speak about it. So I'll speak about controlled studies, naturalistic studies, and longer-term extension of first episode studies. So we try to get everything in the literature to give you the latest data on the drug efficacy. And this is one of the meta-analysis from Stefan Leucht and John Davis and I. And basically what this is showing is virtually all the newer drugs do better than Haldol. Everything on the left side of this white line means it's doing better. Just saying don't use the old first-generation drugs unless you have to for financial reasons. And then, as you how many of the residents heard about Katie? No, it's not the girl you dated. The NIMH study. That was the $42 million study. We were part of it at Stanford, and that study, they came out with the conclusion that all the antipsychotics were equal. Davis and I redid their data, and we can show that our data of all the meta-analysis compares exactly with their data through the 3 phases. Basically, there are 3 drugs that do better than all the others, and those 3 from the residents, just shout them out. Clozapine. What else? Olanzapine and Risperdal. Thanks. Okay, so those are the 3s that I want you to know, and we can show, again, this is all in my 2011 paper. Don't worry about it. The Katie data is the same as ours. And we then did 6 different ways of looking at the same thing, essentially found the same thing in terms of drug discontinuation and efficacy, etc. This is the latest piece from Leucht. And what you can see on this is important. Here's clozapine, and then you see amisulpride, which is not in this country yet, but we're bringing it. I'm actually working with a couple of guys to get it into this country. And olanzapine and risperidone are the top 4 drugs in terms of efficacy. A lot of these other ones, as you go down the list, we don't know exactly how good they are for one reason. I don't know if anybody knows the reason why there's been no head-to-head studies. Because if you work for a drug company, design a study of your new drug against clozapine, olanzapine, risperidone, and it doesn't work, you are fired. So that's why we don't have the head-to-head studies. In terms of negative symptoms, very tough. This is not a great slide, but essentially there isn't much change in terms of our new drugs help a little, but not terribly much in terms of negative symptoms. A lot of people use aripiprazole to pep up the patients. I'm not sure that it's totally effective. In fact, I was the first guy to write about the negative side effects of aripiprazole. And the other thing that I've been doing, again, I'd love to hear your opinion. I'll sometimes use a stimulant like Ritalin to get patients going in the morning. And I find that I've never had a patient get, quote, addicted or high. They use it just to get going. And I already mentioned this. Are there any cognitive enhancers? Answer, no. So in summary then, in terms of the new medications, the ones on the far right of the slide, Sapphirus, iloperidone, and I did, when I was at Stanford and over in my new job, I've tested all these new drugs. They all work. They have some benefit for negative and cognitive symptoms, but not better than the 4 I told you. The side effect profiles look a little bit better. They don't have the EPS and tardive that we've seen. And varying patients will get varying other side effects. But the side effect profiles of the new drugs definitely are good. And I'm still pushing the notion that really the best drug we have for, quotes, treatment resistance is clozapine. So again, I don't like to think of treatment refractory. Almost everybody that I've seen gets some benefit. The only question is how much. And what Braff tells me, that's probably based on what the genetic view looks like. And I would throw in, Braff and I heard, how many of you know who Mary Kay King is? She's at the University of Washington. If none of you, if you walk away with nothing else, she's the woman that has looked at breast cancer and genetics and treatment. And what has she found? If you've got a family history, or if your genes really look bad, you do the radical surgery, as in, who had the radical surgery? Somebody reads the paper here? Angelina Jolie. And if it's not so bad, then you do a lesser procedure. So this is what BRAF is working on, to try to look at genetic factors and family history to figure out what we do in schizophrenia. Interesting. So these new medicines, they all look reasonable. We don't know how they work in the long run because no one wants to run the head-to-head studies. And how they do in terms of metabolic issues, long run, we don't know, compared to drugs like olanzapine, which we know puts on weight, as does clozapine. So there's a lot we still don't know, and I've been encouraging people here to start doing small academic clinical trials to try to answer some of these questions. What do people look like over the long run in terms of not only their efficacy but their side effects? So having said that, that brings me to the study that I did over these last 2-3 years. And the question is, should we give our patients with schizophrenia medications over their lifetime, rather than the current data suggests? How long should you treat schizophrenia, where we have data that it's efficacious? Any of the residents know that? Faculty? How many years do you recommend? Damon?
I would say at least 1 or 2.
2, 3, yeah. It's actually up to 6 now. Stefan Leucht has data showing 6 years. You take your medicine, you do better than you don't. And what I did in this study, I asked 3 questions to every single patient with schizophrenia that I saw at Stanford. The first question was, on a 1 to 10 scale, over the 20, 30, 40, 50 years you've had this illness, how did you take your medicine? 10 was I took it every single day, never missed a dose. 1 was I hardly ever took it at all. 5 was somewhere in the middle. And I knew these patients and their families cold, so I was relatively sure that I was getting right answers. Being aware that patients could shade it either way. The second question was, how did your life turn out on a 1 to 10 scale? 10 being, hey, I had a couple friends, I've been working on and off, my symptoms aren't too bad, I've never been hospitalized. 1 being, it's a disaster, I almost killed myself 3 times, I've been in the hospital most of the time. And then we did a global assessment of functioning scale, both our team and a blind rater blind to adherence. And then we did, on a 1 to 7 scale, how satisfied are you with your life given that you had this illness? Interesting. And this is the article that you have in your hands. Let's see. Oh, I'm sorry. Okay, so it was a naturalistic study, single blind to adherence, 35 patients, that's everybody we saw, mostly white, single, unmarried males, but some others. The ratings were collected by our team, me and a rater blind to adherence. Jake Ballin was the blind rater. And I've mentioned the different scales. And what did we find? It's hard to see these slides, but basically, in the article, you could see them better. We redrew these graphs. What you see is, the better the compliance, the better the outcome, and the better the life satisfaction. The line goes up like this. just straightforward, significant at the .001 level. We had Helena Kramer from Stanford do the statistics. So it was fascinating to see the outcome of this. And as I said, this article, you're the first audience that's actually seen this data and seen the article. A lot of reasons not to believe this. Was not a randomized controlled study. Is obviously confounding with genetic defects or severity. In other words, you could argue that the patients who did well were the ones with the least genetic problem, and the patients that did badly had the worst genes and the worst early childhood severity. I see Tom Anders in the audience. Or you can argue the patients' reports were inaccurate. I doubt it. Or the sample was too small. Helena says we got just enough. And the sample was only a Stanford sample, which is why I want to go back and look at my UCSF patients to see the same thing. I can tell you that I'm also doing this at two other sites, a VA site in Florida with one of my students, and a ghetto population in Oakland, and we're finding exactly the same outcome, for better or worse. So the data suggests, it doesn't prove, the better the adherence to antipsychotics, the better the lifetime outcome and lifetime satisfaction. The worse the adherence, the worse your outcomes can be. We had one suicide, and we had two, 3, 4, 5 patients who just had really difficult lives, and they correlated, doesn't prove, with their very poor medication compliance. So, in summary, of what we know about medicines, an efficacy, these the 4 guys, clozapine, risperidone, olanzapine, better than almost all the others. Treatment persistence, same issue. Positive symptoms, I love risperidone and especially olanzapine. Olanzapine's fallen out of favor because of the metabolic issues. I'm telling Lily, I've been following my patients for a long time. A lot of the olanzapine patients that put weight on early can take it off if you put them in a weight program. So I'm still a believer in olanzapine for what it's worth. And in terms of negative symptoms, again, they're all equivalent. Maybe there's one study, aripiprazole, that did better than risperidone. In terms of EPS, the story there is mostly risperidone and Haldol. Although if you use Haldol in low doses, it's not looks not too bad. 2 to 4 milligrams I'm talking about. There's really not enough data. We're hardly seeing it anymore. In terms of weight gain, clozapine and olanzapine are the main culprits. Significantly different than the other drugs. What I tell the residents is if you put, these people don't have a lot to do. I put almost everybody into a weight program, exercise. Everybody goes to the gym 2 times. I take them out, play some pickup basketball with them, whatever works. So really the bottom line for the residents is efficacy versus side effects, balance the risks and benefits. And what I argue for the residents is overshoot. What you want to do is make sure they're covered with medicine, and then you deal with the side effects afterwards. And this slide just covers what I just said about side effects. I have a chart that I put together. Again, I've told you the main issues. The new ones all looked pretty good. And the main issue is the weight gain right now with some of the drugs. So what I'm telling the residents, learn a few of them. If you want to rev up patients, zip or aripiprazole or even stimulants. For the patients with high cardiovascular risks, which is a lot of patients, use the drugs that don't put the weight on. And always evaluate the risk versus efficacy, and you have to monitor. So I've said the 4th great revolution in psychiatry The first being Marty and I broke in with the psychoanalytic revolution and the biological revolution, and now we're into back to being real physicians and checking weight, metabolic parameters, and other medical issues. We've become almost like internists as we do good practice. So I've been really pushing that with the residents, keep up with medicine. And which brings me to the important part of the talk in terms of having said that about results. Let's just speak to what exactly do you do. So this looks, I like this slide because it shows a double rainbow I took off the porch of my house, and there's a good future ahead, I think, for us. And so let me put this together, and it's I can tell you these are all this is not industry biased. John Davis and I did a study of the study of academic versus industry. We found much more bias in academics than industry. What you want to do is lower morbidity and mortality, try to raise the life expectancy, and increase quality of life. So the goals, number one, in the acute inpatient unit here, we want to get a response. Try to lower the positive symptoms as much as possible, and then work towards step 3, avoiding relapse for the reason I gave you earlier. That is, it does bad things to the brain. And what you want to do way down the line is improve vocational role fulfillment, independent living, and social relationship over the next couple of years. And this can actually be done with virtually everybody, but you just have to medicate hard to do it. And I've already talked about the decision making. I always, from the time I was here, I'm funny, I came from back east with a real bias toward family intervention. And I published the first edition of our family therapy textbook. Nick remembers that here. And I always worked from whatever disease I had, wherever academic center, with a family member. And everybody's got somebody. I mean, even a guy like me, there's somebody that cares. Stanford, there were people sleeping under 280 that had I would bring in the person that was looking after them. So I always work with a significant other, and you try to get from the patient and the significant other what's worked and what has not worked, and why not. And that's been extremely gratifying. I've got families that stay in touch with me over 20 or 30 years. We don't blame the family anymore. We work with them as a team. My standard rap is you, the patient, you, the family, and I. We all need each other. No one of the three of us can do without the others. So that's a standard rap I have. And the different recommendations for acute and long-term. I've made the major point about acute treatment. Acute treatment, don't pick the best, most efficacious drug that you think will work over the lifetime of the patient, not the one that'll stop the symptoms immediately in the short run. So, for example, the drug companies are marketing very hard, use their new drug in the acute setting, and because we know it works better than placebo. Duh. Don't do that. Pick one of them. For me, what I'm recommending is pick one of the most efficacious drugs and then deal with the side effects. And then over the chronic phase, what you want to do is prevent the relapse, improve functioning, minimize the residual psychopathology and cognition as much as you can. Prevent suicidality and violence. And again, what's the rate of suicidality in schizophrenia? Somebody yell it out. 10%, yeah. So you want to try to lower that. And again, you all know, despite what you read in the paper, level of violence with schizophrenia is lower than the general population. When it's done, it's often so bizarre that it hits the headlines and so many people involved. and you try to, the next point is minimize adverse effects and try, for the reason that the follow-up study shows you, you want to get treatment adherence over the lifetime of the patient. Because if you don't, what you're getting is not only bad functioning, but they smoke, they eat too much, blood pressure goes up, you have a higher chance of arteriosclerotic heart disease, diabetes, etc., etc. So that's why I've been pushing the notion of being like a real medical doctor as well as a superior psychiatric physician. And it's interesting to me, Dilip Jesting and I have been talking a lot. He's been the guy that's done some long-term follow-ups. And it's interesting. People don't know that with schizophrenia, you get better over time, many people, after the acute episode. Even about 10%, you can't tell any difference. And again, the Alan Sachs thing I was showing you, John Nash, you could tell he had it. But Alan Sachs, you can't tell anything that is wrong. And how to do that, this is a key slide. You have to, A, provide appropriate drugs and support for taking them. That's adequate dose, adequate duration. Provide appropriate psychosocial intervention and support. That means you can't just throw drugs at people. You know, having just come back from a trip in Europe and last year in Asia, I mean, the docs there who, there's not as many of them in the clinics, they just get burnt out and barely talk to the patients. Provide appropriate rehab. I'm never above going to for division of voc rehab, et cetera. And as I keep hitting, work with the family and significant others. If they don't have somebody, get them a caseworker. Lisa talked a little bit about that last week. And Peter Wyden put this slide together. It was my student in New York. The first thing you do, this recovery model, the first thing you do is get stability, the bottom here, and then you work to reduce the burden on the family and significant others, and then way down the line, you try to improve function. The key issues then is compliance, because there's a penalty for each relapse. Sam Keith shown this very nicely in 2001. And the secret is consistent contact with the treatment team. I see my patients regularly, anywhere from every week to every 3 months. I've got patients here. I've still got patients in New York. I've got patients in Japan. And I keep in contact with them. We now have Skype, FaceTime, et cetera, and ongoing contact with the significant others I always see them on a regular basis, regardless of what the patients say. I don't want to talk to my parents, or I don't want to talk to my spouse. And the answer is, when you get them in, they appreciate it, because they're very dependent. This illness makes you dependent on others. So it's important to understand that for the residents, and I explain that to the family. The consequences, as I said, these things can happen. To me, I don't have any favorites among the different kinds of psychotherapies. I put this slide together of stuff that befriending. CBT is now the rage. Cognitive remediation, psychoed. I'm big on psychoed. We did a lot of that while I was here. We had a weekly program on inpatient service for psychoeducation. And so I spent a lot of time with doing psychoed for the patients and the families, and not just once, but over the lifetime of the illness. And now I've been giving them, recommending Lloyd Sederer's book on mental illness and their families. Social skills training, supportive counseling, and of course, the psychodynamic supportive therapy we all grew up on. Having said that, what patients want from us is, as best I can figure, an ongoing relationship. an explanation of what's wrong. They actually want to know the name of their illness. This is not the 1970s anymore. And what to do about it. So I always outline the treatment. We set goals together, and if they don't want to do it, I say you're going to have to find another doctor. We want to deliver cutting-edge treatment. And patients are willing to accept a modest improvement in their symptoms as long as you help them deal with their side effects. So the wrong thing to do is every time a patient complains of a side effect is to switch. And we know around the world, 1/3 of patients with schizophrenia get changed every year from their medication, probably inappropriately. And as I said, the specific strategies are adherence, I measure symptoms 1 to 10 every visit, and working with the patient and family as they need help in dealing with this illness, which causes so much burden on the families. So what you don't want to do is use the first-generation agents only. You don't want to do polypharmacy. As I said, I'm never above adding a stimulant. I'm not above Ativan on a PRN basis. But those of you who know the literature, I did in the Katie study, before we had 50 patients at Stanford. And before we randomized them to their antipsychotic, the first thing I did was take them off there were 20 patients on antidepressants. What happened? They cheered up. We took patients off their mood stabilizers. We had 17 patients. And what happened? Nothing. One patient was irritable, and I put him back on his lithium. He's still on it. I'm still not sure he needs it, but he has it. So I actually published this, and I make a big point of don't do polypharmacy. Pick your best antipsychotic and do monotherapy. And use clozapine, and we're really pushing long-acting agents now, which you can start in the acute setting, some of them are now we got 3-month preparations, and I'm working with a 6-month implant of risperidone, which is terrific. The patients love it. And don't be above IM treatments. In Europe, what they do, patients come in with schizophrenia, they see their doctor, they think they're getting terrific care because the nurse, as soon as they walk in the door, the nurse lays them down on a stretcher, starts an IV or an IM medication, and they think they're getting great treatment. So don't be above using long-acting agents. And again, I keep hitting this point of psychosocial, psychoeducation, or CBT, whatever you're doing, over time. And as I said, the drugs work best on the positive symptoms, like olanzapine, risperidone. For high denial patients, use IM. The literature is mixed on that. The studies that show for the average patient, IM versus oral, show there's no difference. But if you pick, there's 2 studies now. If you pick patients who have high denial or don't believe there's anything wrong, and you put them on long-acting agents, surprise, they do better than if they're on orals and stop it. Don't keep switching if you get a partial response. The task for what I tell the residents is pick your best drug and try to figure out if this is the best you can do. Don't push too hard, don't push too little. You want to pick just the right dose. And I like Lisa's slide last week. How many people were at Lisa Dixon's talk last week? She had this wonderful slide of the 3 bears. So I did the not too much, not too little, just right. When I did this lecture in Japan, I speak a little Japanese, but after the talk, out of 300 people, and I asked the translators how it talk. It's terrific. I said, what do you think of the 3 bears analogy? Never heard of it. So you never know, is the point. Don't use antipsychotic polypharmacy. Use clozapine. That's the best we got. And hang in there for a year before even thinking of switching. Side effects, I've already spoken to this. And as the treatment tips then are monotherapy, Goldilocks, individual and family. And if cost is an issue, you can use the Haldol. A lot of places around the world don't have the money we have, and I know our president is going to do something about that to get our community mental health better, of course. Nobody's laughing. Anybody awake here? And a lot of the second generation agents now are coming off patent, and they're really not as expensive. I put Lisa Dixon's slide in from last week. This is what she is. She didn't talk about this much, but what Lisa has been pushing around the country is this coordinated specialty care for schizophrenia, having a specialty clinic in every site, and where you use evidence-based drugs, psychotherapy, family support, supported education, case management, and peer support. I have not mentioned peer support. Peer support's terrific. I love NAMIs. I send everybody to NAMIs, to the NAMIs, and they're all over the country. So in summary, John and I have been saying that all the antipsychotics are a group. They're all different in terms of efficacy and side effects. Individualized treatment, you'll be a hero. And share what you're doing. Work with the patient and family as a team. Here's a view from Land's End. And maybe that's a good place to stop and take questions as we all work together to try to improve the lives of patients and families with this serious, disabling disease. Thank you. Nick.
From your Stanford, did you have any comments to make about the advantage and disadvantage of drug holidays?
No, I have no comment to make on drug holidays. I mean, most of my patients, they ask me that, and the reviewers asked me what I did in terms of medication. Very standard. Everybody got adequate dose and duration. I didn't do drug holidays. That's your question, right?
Do you recommend drug holidays?
No. No, I don't recommend drug holidays. Simply, I don't know the data. I don't think, John Kane and I have talked, I don't think it works. He's not recommending that anymore. Yes, sir.
You mentioned stimulants a couple of times, and I'm not as familiar. What can you tell me about the studies that have been done around stimulants in patients with schizophrenia?
What can I say about the studies?
That have been done around stimulant use for patients with schizophrenia.
Stimulant use?
Yeah, you mentioned use of
Yeah,
stimulants.
there are no controlled studies. It's all anecdotal, non-evidence-based. I've got maybe a handful of patients that take Ritalin or Adderall, don't seem to abuse it, and it seems to help them get going in the morning. My patients, when they're on clozapine or Rethinking, slide out in the morning, can barely get going. Your patients probably terrific. Mine can't get going.
So you're using it mostly because of the side effects, the sedating side effects? But you're using it mostly because of the sedating side effects of the atypicals?
Maybe. I'm not doing it for that, just to get them going, but it does seem to help that. Thank you for making that point. Yes, ma'am.
More recently, people are trying again to look at using two agents at sort of lower doses to try to mitigate side effects, but still get receptor occupancy. Do you have any that you're saying no polypharmacy?
Yeah, Steve Stahl and I, hard as it is to believe, went around California to the state hospitals to show them the data on using one or more antipsychotics. Every one of the antipsychotics has a study showing that plus clozapine or that plus risperidone does better than either one alone. There's no support. There's anecdotal reports, and having said that, all of us have maybe one or two patients on two antipsychotics, including me. I'm trying to think I think I got one. But the answer to your question, the academic answer is no, don't do it. You get you get interactions, side effects, and you might be lucky if this one patient responds to two, but
There's good studies going on.
no. Nobody believes it's worth doing. Yeah, so if you want to fund it, we can do it. Or if you and I, we can do a survey and see. If you'd like, I'll write it up with you. Damien.
I'm intrigued. You said that you found more bias in academic studies than in
Yeah.
Can you tell me more what you mean?
Davis and I did a study of who's screwing around more with the data, the drug companies or the academicians. Where are the studies designed to show the drug works or their academic career gets better? And we published it. It's in the Neuropsychopharm, the ACMP journal. Basically, Davis is a stickler for this, and he says the drug companies can't screw around with what they show you is what they got. They design the studies to show their drugs work. Anybody knows that. That's a business. So if they do something wrong, they get billions of dollars fines and they go out of business. So they don't do it. I think the point you're making is take the drug company studies with a grain of salt. True. I think that's your point, right? What's behind your question?
I'm just wondering, it sounds like what you're saying is that the incentives of the drug company studies may be more obvious and we sort of ready for them.
Yeah.
We should also be ready for the incentives and studies funded otherwise.
Yeah, no, it's tough to do academic studies, as we all know, and people often write up their results, and it's not always the way the data is. That's why we have reviews. The journals have gotten really tough on this in the last 10 years. And it's not a big issue. It's just by way of reassuring you that the evidence-based data that we're showing is reasonably accurate. Yes, sir.
I'm a social worker at UCSF. We deal with the most acute clients in the city, mostly psychotic disorders. And it's really, really difficult to get clients to maintain med compliance. So
right.
We're always pushing the IM shot. But,
right.
I'd say at least half the time people use it. So the question is, what can you say to clients to help them feel better about taking the shots? And just, what's the evidence that you can give to them? Because I'm big on psychoeducation that's going to convince them that this is really important to take.
Great.
And things like you're saying, it's every time you have a new break, your brain deteriorating. So it doesn't, I guess they don't believe it or don't want to believe it.
You're listening. Very good. Yes. Yeah. So what do I say? What I do is I tell them that if you don't take your medicine, you're going to do much worse than if you do. The best way to take it is long-acting. Why these long-acting IM shots? Why struggle with remembering your dose every day? We can give you a once a month or once every 3 months now, and once every 6 months, as I told you, is coming. It's easy. I give them my experience. The patients love it. They get no side effects. It's easy for them, and they're getting the same partial efficacy they got on the orals. So I make a big point, and I use a strategy, which I'll tell you since I'm among friends here. The strategy I always use is I say, look, you got to do this or else I'm not treating you. But that's really just it's a phony threat, because I always end up treating. Usually the patients will say, okay, I'll take it because of you, you're stupid. But I'll do it. They do it because they're dependent. So that's how I do it in answer to your question. Yes?
On the earlier slide, you said that use of weight gain, that risperidol and aripiprazole and thiamine were equal in weight gain?
Yeah, I think that's right. Do you have different data?
Well, just in my experience in clinical where you said thiamine has much greater weight gain than risperidol and aripiprazole.
Yeah, not much. It may have a little bit more. I don't use quetiapine for schizophrenia. I use it for mood disorder, for bipolar. And the way I found that out was by speaking to the drug company guys themselves who had developed the drugs at the, I forget which company. And so I don't use it. And yes, it has a fair bit of weight gain. Maybe it's a little bit more. I think risperidone is 2 to 4 pounds. Quetiapine may be 6, something like that, average. In some patients, maybe more. But your point's well taken. That's the answer, best answer to your question. Aripiprazole, again, it varies. I did another study when I was at Stanford. I took patients who had weight gain or other bad side effects, and I put them on, I switched them from the risperidone, clozapine, the olanzapine, to aripiprazole to see what would happen. And I did it with Jerry Reven, who's almost a Nobel Prize endocrinologist. We looked at metabolic parameters, and guess what we found? the efficacy wasn't as good, and the side effects, it wasn't worth it in terms of switching to Abilify. But thank you for asking the question.
Did the weight gain get better?
Some patients, I had a couple. It was nothing striking in answer to your question. I published it, so we can both look it up. But as I remembered, it was nothing striking. Yes?
Do you have like some kind of personal approach to diagnosing a depressive episode in chronic psychotic patients?
Do I have a protocol for diagnosing schizophrenia?
No, like a depressive episode.
Oh, yeah. Well, they use these different scales. But the problem is David Sheen's scale and the Madras and the there's one with a Canadian name on it. What the problem is, you say to a patient, "Are you depressed?" And they say yes. And then you get an antidepressant. Because then what you have to do, what I've been telling our residents here, is ask what they mean when they say they're depressed or they're anxious. Because, as I said, patients with depression often mean demoralization, or my life doesn't look good, or my doctor is depressing to me. Or when they say anxiety, they can mean 20 different things. So I do a 1 to 10 mood scale. How's your mood? How much crying are you doing today? How suicidal? That's how I do whether they're depressed or not. The key depression symptoms are lowered mood and anhedonia. Yeah, go ahead.
And so what is your threshold for then antidepressant medication use?
Well, if somebody's crying every day and they say their mood is 9 on a 10-point scale, I'll give it to them. But maybe I got 1 or 2 patients on it. Sam Cyrus, who's done at Hillside, has done the original research on this, and we went back and forth. We had letters. We ended up agreeing that it's probably being overdiagnosed and antidepressants don't work. If you have a real major depressive episode, as you are suggesting, yeah, do an antidepressant. I also don't believe that there's anything known as schizoaffective disorder. Go ahead.
I want to add to that because I think that there's some newer data that I think that the problem here is that we're thinking antipsychotic has some specificity. Antipsychotics actually treat depressive symptoms. And so the way I tend to think about it is, if you're going to start somebody on antipsychotic, if you think the risk-benefit is in its favor, you should expect some improvement in depressive symptoms on the same scale as if you gave them an antidepressant. And so the question about when to add an antidepressant is the same question you would ask if you started an antidepressant, which would be and the data is very similar. Augmenting has a very low effect size strategy. Right? So you just have to think about adding an antidepressant. It's just a low effect size strategy that you should do only after you've assessed response to the antipsychotic. There's a fair amount of data that adding antidepressants early, you don't get any benefit in symptoms over just an antipsychotic. It's because antipsychotics also treat depression.
Right. No, Damien's answer is much better than mine. I like that. Absolutely right. Yeah, Dan Casey and I did 2 studies early adding an antidepressant. We couldn't find any benefit.
It should be similar to like SARB, right? Adding the second antidepressant is a very small effect.
Right. And there's a recent paper out that Stefan Leuk did on this very question of antidepressants. And he ends up, I think it was in the archives, as a matter of fact, and he ends up saying they help a little. So I called him up. He's in Munich. I know him we played basketball together. I called him up. I said, Stefan, would you give your kid an antidepressant? He said, you're right. It's a very small effect, and don't put your mortgage on it. But thanks for the question. Marty.
So, speaking of psychodynamics.
Yes, which we love.
The importance of having the significant other with an identified psychotic patient. I think that's very important because 3 of you, in a way, can process sometimes the crisis events that may precipitate a relapse. So, elaborate.
Well, Marty can say it better than I can. We both came out here at the same time. We came out with the bias that it's really important to try to understand the patient's, quotes, mind as well as the brain. We're still having trouble accepting that they're together, but other than that, we work together to try to understand a crisis situation by putting together not only what the patient reports, I'm anxious, I'm having trouble with my spouse, but we fold into that the spouse's viewpoint. Hey, this guy's impossible to live with. You know the joke about one woman says to the other, how's your husband? The other woman says, compared to whom? And you try to put the spouse's point and your own perception of what's going on to try to make sense of it. Does that speak to your point, Morty?
Yeah.
That's really cool. I found this invaluable. I mean, so I've had these, as I said, lifelong relationships to the patients that I've treated here, New York, and at Stanford. And it's been nothing but helpful to me in trying to make the lives of the patients and families better. Yes, sir.
Among the long-acting injectables, do you have any preference?
Well, the Prolixin Haldol preparations are fine. They have a little bit more side effect than the new risperidone preparations, the paliperidone and Vega. So I've been pushing that if you can afford it. Having said that, I'm comfortable with the old ones. Does that answer your question? Well, what's your experience?
Well, I'm kind of wondering about the comparative studies of monthly injectables, not the fluphenazine, not the halodecanolate, but the new once a month or every 3 months injectables. Any comparative studies? No, there are no comparative studies. They all compare them to basically to placebo. They can show they're doing better. That's what the drug companies are doing. That's what I tell you. They don't want to do comparisons. They don't want to show it's not worth the extra money. So they haven't done the paliperidone versus Haldol versus Prolixin. They have not done. I've been working with those drugs, and I can tell you they're fine. But comparatively speaking, that's why I told the joke. Compared to whom? We don't know the answer to your very good question. Damon.
I want to make a psychodynamic comment about injections. Because I feel like I understand the data that with people, high deniers, you should think about injections. That's certainly true. Those are the people who are going to get the largest increased effect. But I really think that one of the big problems with our use of injectables is that by the meaning of them is framed as if you're a bad patient, then you get the shot. And I think that's a really poor way to approach injectables, as opposed to, this is my best chance at measuring how effective this medication will be for you in the shortest amount of time, right? Which is what I think they actually offer over and above the denier sort of question, which is true, right? But those people are going to select it out as being deniers. I'm thinking about them more proactively. And we thought about it, but it's so hard to implement because people hear shot as your right. Why are you giving me the shot? This is kind of the meaning. And it's just a comment that I feel like we as a system reinforce by the way we use injections. As we sort of use them as like these last chance medications, as opposed to, why not think about the injection at the start and then you transition to the oral, but you've got all that data that every month matters in first episode treatment, and you get the best data. If you need to switch, you want to know as soon as possible. Right? I want to know right away. I don't want to wait until you fail 3 trials and I don't know if you're taking your pill.
I like that. What does Professor Horowitz say?
I think the meaning of the medication is really very important, and that's why I think it is important to have a triad of you, the patient, and a significant other, so that the fantasies about what the medication is going to do go in the direction of a positive placebo effect rather than a negative.
Absolutely. Yeah. And Damien's also making the point, the treatment alliance is crucial for the residents, so that you don't want them to feel that you're thinking they're bad. I agree with you 100% on that. Yes?
In your long-term studies of medication adherence and outcomes, did you find any differences in response between patients with schizophrenia who presented primarily with positive versus negative symptoms? And if so, would your recommendations or even the way that you explain benefits of antipsychotics be different depending on the symptom presentation?
Yeah, well, the question is, depending on whether patients present with positive or negative. As Damien said, this is a complicated disease, lots of different symptoms, and most of the patients present with some positive and some negative. You get hardly anybody. I'm just trying to think. The only patients I have that don't have much in the way of I have a couple patients with minimal positive symptoms, a lot of negative symptoms. They don't want to do anything. They don't want to talk to anybody. They're people that they're people that have had a heavy substance abuse history: cocaine, meth, heroin, alcohol. So for them, it's very tough. I like that global assessment of functioning scale. They're in the 30 to 40 range. I want to bring them from 30 up to 40. 2 friends, a volunteer job, get up in the fucking morning. That's about what I'll do, and I'll give them my best drug rather than any specific drug. Yes.
So, understanding the chronic nature of schizophrenia and the history of relapsing, it kind of makes sense to be a long-term therapy. But is there a point if a patient has been stable for a long time?
Start again.
So, just kind of understanding the chronic nature of schizophrenia.
Yeah.
And kind of the risk of relapse in the future, and makes sense to be on long-term therapy. But is there a point if a patient has been stable for a long time, you consider letting that go?
Very, very good question. Do you ever try stopping the medicine if the patient's been stable? Great question. And so I'm never above saying, hey, this is what the data shows. But if you want to try, you might be 1 in 100 or 1,000 that doesn't need the medicine now that you're 60 years old. And I bring the family in and say, let's keep an eye. I give patients my cell phone number. Call me if you start to get a relapse as I taper your medicine down and if you discontinue it. So I have patients checking in all the time as part of my follow-up med management. Great question.
In your experience, do they tend to then relapse
all the data shows if you stop the medicine, people relapse. Now there are, obviously, with the genetics that I was telling you about, there's got to be some people that don't need it for a lifetime. That's why I like that breast cancer analogy. So I'm never above trying it.
I really appreciate the warmth that underlies all of this work, and even the way you are with us right now. I think the relational warmth that you bring to this has got to have been a major contribution to the work that you've done. And I think bringing in the family member or the loved one stabilizes the relational aspect, probably reduces the transference. And so I just want to say I think that must be a tremendous aspect of this. And you're showing it to us right now.
Well, thank you. That's the nicest thing anybody said to me all day. Where's Canis? He just insults me. My old student. No, is he still here? The teaching point is, I've found working with chronic schizophrenia very rewarding. And when I did this paper for the journal, the American journal, Carol Tominga, who I know very well, is this major. She said, it's only because you're so warm and friendly and give such good treatment. That's why. It's not the medicine. It's just you. I said, come on, Carol. In the paper I make a point of saying there were some of those disastrous outcomes were from a few of the patients who had very good relationships with me. Wasn't enough, is the point. They needed the medicine. So I think that's it. I was just going to say, I respin your question. The real answer is good therapeutic alliance. I'm sorry more residents aren't here. Plus the medication, plus the psychotherapy, and et cetera, et cetera. I mean, that's why I threw...
Oh, sorry, I didn't mean to interrupt. I thought you were taking a pause on your answer. Please, go ahead.
Yeah, well, I was just going to say that's why I put Lisa Dixon's slide in at the end, where she's got it all summarized, and she's making a whole career on this comprehensive care thing. She's done it better than I have, which is true test of how your students are learning. They do better than you. Yeah, go ahead.
No, I was just going to say thanks very much. I think the questions have sort of trailed off. I wanted to thank you for presenting this morning. If anyone wants to stick around, you have about 10 more minutes if they want to ask individual questions. Thanks very much.
Thank you.